Okay, so coming to the last talk of the day. So radial neck fractures in children are rare injuries. However, it is important that we know the correct method of reducing these fractures, because it depends on the treatment how your result is going to be. Improper treatment of these fractures can lead to elbow stiffness and problems. Okay, so first we need to understand as to what is acceptable in radial neck fractures, which are the fractures we need to reduce, and which are the fractures we can just treat with in situ casting. So for that, we need to look at the amount of angulation, the amount of displacement that is there, and that is given to us, the O'Brien's classification is there, where type 1 fractures are with angulation less than 30 degrees, type 2 30 to 60, and type 3 more than 60. So it's general. It is accepted that fractures with which are type 1 less than 30-degree angulation you can accept. However, for type 2 and type 3 fractures, you generally need to reduce these fractures. Age is another factor which decides your treatment modality. The higher the age, the more the tendency to get anatomical reduction comes in. In the younger children, you can accept a slightly higher angulation. So what are the reduction methods that are there? And obviously we know that there are closed reduction methods and there are open reduction methods. However, when it comes to radial neck fractures, it's important that we should make all attempts possible to get a closed reduction. Because whenever we do an open reduction in a radial neck fracture, the results are inferior as compared to a closed reduction. So closed reduction methods, as you can see from this slide over here, there are a number of methods which have been described. However, for it may appear daunting to remember all these methods, but all that we need to know is the principles of reduction. If we know the principles, it becomes quite easy. So let's see each of these methods one by one. So the Patterson method is the one which was the first described, and it was described way back in 1934. So it is a maneuver where the elbow is held in extension and supination. The assistant holds the arm and gives counter traction. The surgeon gives traction and virus, and with thumb pressure, the radial head is pushed back into position. So this is just a video which shows that. So the assistant holds the arm and gives counter pressure on the medial aspect of the elbow. The surgeon giving traction and virus stress, and with the thumb pushing the radial head back into position. So this is the Patterson's maneuver. Jeffery slightly modified the Patterson's maneuver. What he proposed is that in radial neck fractures, the displacement is not always bang lateral. The displacement is slightly posterolateral in most of these cases. So he said that what we have to do is, he added one more step to Patterson's maneuver, and that is pronate the forearm till the radial head is seen in perfect AP profile, as it is seen in this X-ray. So Jeffery added one step to Patterson's method. Neher Torch went ahead and added one more step to the Jeffery's maneuver. What they said is that in these fractures, generally the annular ligament is intact, and therefore the radial head actually is stable, whereas the distal radial shaft is unstable, and it is the fragment with the longer lever arm. Therefore, what he proposes is that the assistant should push the radial shaft towards the stable radial head. So just to summarize the Neher Torch method, elbow is held in extension and supination. Pronate the forearm till radial head is seen in perfect AP profile. Assistant holds the arm to give counter traction. With the other hand, assistant pushes the radial shaft towards the radial head. Surgeon gives traction and virus, and with thumb pressure pushes the radial head into position. We'll just see a quick video on that. So the assistant holding the arm, giving counter traction on the medial aspect, as well as with the thumb pushing the radial shaft laterally. The surgeon slightly pronating the forearm till the radial head is seen in AP profile, and then pushing the radial head into position. Right? So the Neher Torch method is nothing but a modified version of the Patterson's method. So these are some methods which have been described in extension. Then there are some methods which are done with the elbow in flexion. So number one is the Kaufman's method, where the elbow is held in 90-degree flexion and full supination. Thumb pressure is exerted on the radial head. The radial head is pushed medially, and the forearm is gently rotated into pronation. Simultaneously, the radial head is pushed back into position. So this is the Kaufman's method with the elbow in flexion, elbow flexed to 90°, thumb pressure on the radial head, and then the forearm is pronated, and as the forearm is pronated, the radial head is pushed back into position. The latest method that is described is the Monson's method. Monson's method again is a maneuver in flexion. Here the forearm is rotated into full pronation, and what Monson says is that in this position, the angulation of the fracture, the apex of angulation becomes anterior when the forearm is completely pronated. And then all that you have to do is you have to push the radial shaft, that is the distal fragment, which has a longer lever arm, you have to push it posteriorly in order to reduce the fracture. So here is a C-arm picture of the Monson's method, and here is a video. Elbow in flexion, pronated, and then the radial shaft pushed posteriorly so that the angulation at the fracture site is corrected. Right. Fine. So apart from these, then there are some methods which have been described. I have no personal experience with these. The Esmarch bandage method, where you wrap the Esmarch from the distal, from the wrist up to the elbow, and it is reported that this maneuver can help in reducing the radial head. Then there is the Metesue technique. Again, I have no personal experience with this method, but here you make use of the hockey bend at the end of a tense nail. So a tense nail is inserted retrogradely from the distal radius towards the radial neck. The hockey stick is used to engage the radial head fragment, and then the tense nail is rotated so that the radial head is reduced back into position. That's the Metesue technique. So all these techniques which I described thus far are useful in reducing fractures which are angulated. However, occasionally you may get fractures like this where the radial head is completely flipped out of position, and it may be difficult to achieve a closed reduction by the above mentioned methods. So in this scenario, I have found that the percutaneous wire leverage method works quite well. Now, one fear that many surgeons have with the percutaneous wire leverage method is that it can damage the PIN, the posterior introitious nerve. However, let me tell you that this fear is unfounded. At this level, at the level of the radial head, your PIN is actually quite anterior. So your wire entry point should be posterolateral, just about say 0.5 mm lateral to the lateral tip of the olecranon. So you take the entry point lateral to the olecranon and touch your wire to the distal radial metaphysis. Then, keeping your wire in contact with the metaphysis, rotate it towards anteriorly until it engages into the fracture site. And then once it engages into the fracture site with the K-wire, lever your radial head back into position. And once your radial head is reduced, you can use the same wire, advance it distally, and use it like an intrafocal K-wire. So by this method, you can reduce many of the severely displaced fractures. Finally, if all these methods fail, you may have to resort to open reduction. However, it is known, there are many reports which say that the results of open reduction are significantly poorer as compared to closed reductions. There can be a loss of range of movement, and most often this loss of range of movement is due to avian or premature closure of the proximal radial physis. So if you are in a scenario where your closed reduction methods have failed, then you may prefer to accept angulation up to 45 degrees rather than resorting to an open reduction in those cases. Finally, coming to some rare fracture patterns, this is a case which has been contributed by Sandeep Patwardhan, and here you can see that, where is your radial head lying? Your radial head is lying posterior to the capitulum. Now, in the normal case scenario, all the fractures that I showed so far, this is where your normal radial head position is in a typical fracture. So here is where you have to understand that there is something known as the Jeffrey's classification. So the Jeffrey's type 1 is the fracture that which we see much more commonly, which is due to a valgus stress to an extended elbow, and here the displacement of the radial head fragment is lateral. It just lies adjacent to the proximal radial metaphysis. On the other hand, a Jeffery type 2 is a much more severe injury. It is associated with an elbow dislocation, and while reducing the elbow dislocation, the radial head gets displaced and it lies posterior to the capitulum. Now we have to understand that all the close reduction methods which I described were for Jeffery type 1. These close reduction methods will fail in case of a Jeffery type 2. So in this fracture, you need to use a special maneuver which has been described by Chotel et al. In this maneuver, you have to actually recreate the posterior dislocation, and once you recreate the posterior dislocation with a K-wire, you have to joystick the radial head back into position. Jeffery type 3 has also been described, wherein the fracture occurs at the time of elbow dislocation, and here the radial head lies almost within the joint, and it prevents the dislocation from getting reduced. Finally, it is not that a radial head, if the radial head is not seen, it is not fractured. In the younger child where the radial head is not yet ossified, you can still get a fracture of the cartilaginous radial head. So this is a case from Peter Waters' trash elbow paper, where he has shown a case of a child who is 2 years old, trauma to the elbow, and you can see that when an MRI was done, it actually revealed that a radial head, which is cartilaginous and not yet ossified, was fractured and lying completely displaced. So that's the concept of trash, that the radiological appearance seemed harmless. Though the radial head is not ossified, it is fractured, it is cartilaginous. So in such cases where the elbow is severely painful and swollen with no obvious evidence of fracture on X-ray, you have to think of the trash lesion. Finally, there is a case of intra-articular radial head fractures. Now this is a case of an intra-articular radial head fracture, a type 3 fracture. Here you may feel that this is a non-weight, this is the upper limb, a non-weight bearing limb, so you can just leave this alone. But understand that the natural history of this type of fracture is very sinister. This usually leads to posterior subluxation and finally leads to radiocapitular arthritis, and can lead, ultimately the end result can be elbow arthritis. So this is not a fracture pattern to be taken lightly, and these fractures need fixation. So to conclude, radial neck fractures are rare injuries in children. Close reduction should always be preferred. Open reduction carries risk of avian stiffness and premature closure of the proximal radial physis. Thank you.